Raghu, Raghu.
Sir, ready or no, sir? వినిపిస్తుందా సార్? Sir, వినిపిస్తుందా?
వినిపిస్తుంది.
Yeah, we'll start, sir.
Yeah, good morning all of you. Sorry for the interruption and the late. Because one of our colleagues who is the presenter today got infected with COVID. So suddenly we sent the message that the class is postponed. But thanks Dr. Jekina Boyna to arrange one presenter on emergency basis for today's critical care topic. The topic is on discussion on critical care paper by Dr. Raghu and the moderator is Dr. Jekina Boyna. Raghu, please start the presentation.
Good morning, everyone. So today, my first question, what I am going to discuss is regarding changes in 2021 guidelines from 2016 guidelines. So sepsis is a life-threatening organ dysfunction caused by a dysregulated host response to infection. This is as per 2006 guidelines. Surviving sepsis guidelines, 3 guidelines only. This is the same definition. They continued with this definition only. What changed is in 2016 we recommend that hospitals and hospital systems have a performance improvement program for sepsis, including sepsis screening for acutely ill and high-risk patients. But what changed is, so same we recommend using a performance improvement program for sepsis, including sepsis screening for acutely ill, high-risk patients, and standard operating procedures should for treatment. Previously, they just endorsed we have to make a hospital and hospital system for performance improvement, but now they changed it to we should have a standard SOPs for the treatment of the patients also. Not only screening and not only for identifying high-risk patient, we should have some operating procedures for treatment also. Every hospital should make a SOP for the treatment of sepsis patient as soon as the identification. So next recommendation comes up. We recommend previously in 2016 guidelines, they recommended QSOFA as a bedside and ward screening method to assess the patient severity. So now they recommended not only QSOFA. So they said that not only QSOFA, SIRS, Muse as a single screening tool for sepsis. They recommended against QSOFA. No, they didn't recommend against QSOFA. Basically, in 2016, they suggested
Hello? Raghu? Anna?
రఘు యు ఆర్ ఇన్ మ్యూట్ అనుకుంటారు, మరి సౌండ్ లేదు.
Anna, ఇది discussion is on paper or discussion on this these guidelines? Sepsis guidelines?
We usually plan is when there is a paper, when they write a question paper, we ask them to present that questions, answers, and discuss on that.
Yeah, question and followed by answer.
Discussion. So దాని మీద not complete paper discussion will be for almost around 4-5 days ఉంటాయి, క్లాసెస్ ఉంటాయి. ఎందుకంటే ఈ 2 questions డిస్కస్ చేస్తాం అంతే పర్ డే.
అదే ముందు క్వశ్చన్ చెప్పకుండా డైరెక్ట్ గా వెళ్ళిపోయి ఏంటి ఐ డోంట్ అండర్స్టాండ్ వెదర్ హి ఇస్ టేకింగ్ సమ్ క్లాస్ ఆర్ డిస్కషన్. ఐ డోంట్ అండర్స్టాండ్.
ఈయన వినబడుతుందా? రఘు వినబడుతుందా? హలో రఘు.
ఏదో అయినట్టుంది.
ఈ లోపల డేవిడ్ ఫోన్ చేస్తుంటే నువ్వు స్టార్ట్ చేయి శ్రీనివాస్ జక్కిన నీ డిస్కషన్.
సార్ నేను ఫోన్ చేశాను, నేను ఆయనకి ఫోన్ చేసి ఇప్పుడే చెప్పినాను, వినబడట్లేదు, మళ్ళీ ప్రాజెక్ట్ చేయాలి. మీరు మిగిలిన వాళ్ళు రీసెంట్ దే కెన్ షేర్ ద క్వశ్చన్ పేపర్. ఫస్ట్ క్వశ్చన్ ఈజ్ ఏంది బ్లాక్ వస్తుంది మొత్తం.
డాక్టర్ మౌనంగా శ్రీనివాస్ స్టార్ట్ చేయ.
నువ్వు నాట్లో రాడు వాళ్ళకి డిస్కౌంట్ చేసి పండి.
హలో సార్, ఇప్పుడు వినిపిస్తుందా సార్?
వినిపిస్తుంది. రఘు, స్టార్ట్ విత్ క్వశ్చన్ పేపర్. రఘు,
సార్
display the question paper and then start the
discussion.
I
informed them, sir. Mohan sir.
Okay, sir.
Mohan sir, I informed him that he is not audible ani. So somebody can share the guidelines. Evaraina
కాదన్నా, మళ్ళా స్టార్ట్ చేస్తా అన్నాడు.
ఓకే, స్టార్ట్ చేయండి. క్విక్ గా స్టార్ట్ చేస్తే బెటర్ కదా.
సార్ ఇప్పుడు కనిపిస్తుందా సార్?
లేదు,
కనబడట్లేదు.
ఇప్పుడు కనిపిస్తుంది,
కనబడుతుంది. యువర్ గైడ్ లైన్ ఇది అయిపోయింది, ఇది అయిపోయింది. స్లైడ్, నెక్స్ట్ స్లైడ్ ప్లీజ్. నెక్స్ట్ స్లైడ్ ప్లీజ్. ఇక్కడ ఉన్నావు.
రఘు, ఐప్యాడ్ కాకుండా ఇంకో ఏదైనా డివైస్ ఉందా నీ దగ్గర ఇప్పుడు?
ల్యాప్టాప్ ఉంది సార్.
అంటే ఐప్యాడ్ లో దిస్ హ్యాపెన్స్, నాతో కూడా ఇలాగే జరిగింది, అందుకనే ఐఎమ్ సేయింగ్ దట్.
అవునా సార్, నేను ల్యాప్టాప్ లో లాగిన్ అవుతున్నా సార్. 2 minutes.
కానీ చేసే ఇప్పటికి 8:59.
So for adults suspected of having sepsis, we suggest measuring blood lactate. This is like previous guidelines only, and they used capillary refill time to guide resuscitation as an adjunct to other measures of perfusion. Till 2016, it was a strong recommendation to use capillary refill time, but now we have many gadgets to know the volume status. That's why they decrease weak recommendation for capillary refill time. And so updated recommendations regarding fluid resuscitation, we recommend that in the resuscitation from sepsis-induced hypoperfusion, at least 30 ml per kg of IV crystalline fluid to be given within first 3 hours. This was recommended in 2016. They said it was a strong recommendation that we have to give, every patient should be given at least 30 ml per kg of IV crystalline, and that should be given in 3 hours. But for patients with sepsis-induced hypoperfusion or septic shock, we suggest that at least 30 ml per kg of intravenous crystalline fluid should be given within first 3 hours of resuscitation. They made it the weak recommendation. We have to resuscitate based on the patient condition. Not everyone should receive. There is no hard and fast rule to receive at least 30 ml per kg. But now they decreased the level of recommendation for this. Is they made it weak recommendation. So
Raghu,
sir.
Raghu,
Sir,
so you are telling only 10 recommendations or all recommendations?
10 వస్తాయి సార్, అన్ని వస్తాయి సార్.
మరి డీటెయిల్ గా చెప్పు కదా. Why they have decreased the recommendation? That is very important. No, tomorrow examiner will ask you recommendation come down.
Okay.
Why it is upgraded or why it is downgraded? Is there any evidence? So when I expect what I expected is, what is new means, I expect that what is the recommendation? Is it weak or strong? What is the level of recommendation, grade of recommendation, and why it has come down? Okay, so that is important. Yeah, please carry on.
So in 2016, they suggested that dynamic over static variables be used to predict fluid responsiveness where available. So we suggest you in 2021, they made it. We suggest using dynamic measures to guide fluid or physical examination and static parameters alone. So nowadays, they endorsed 2016. They advised to suggest dynamic or static variables. This they recommended, but now they said that dynamic measures for fluid resuscitation we have to use. So what are the remarks? Dynamic parameters include response to a passive leg rise or a fluid bolus using stroke volume variation, pulse pressure variation, or echocardiography where available. So we recommended that administration of intravenous antimicrobial should be initiated as soon as regarding antibiotics. Administration of IV antibiotics should be initiated as soon as possible after recognition and within 1 hour for both septic shock and sepsis without shock. But in 2021, they made that for adults with possible septic shock or a high likelihood for sepsis, we recommend administering antimicrobials immediately, ideally within 1 hour of recovery. Previously, they suggested that in 2016, we can give up to within 1 hour, we have to give, but in 2021, they made it immediately whenever you identified there is a possibility of septic shock or high likelihood of sepsis, we have to immediately give the antibiotic.
సో ఏముంది లాస్ట్ టైం కూడా 1 hour చెప్పాడు కదా, అంటే డిఫరెన్స్
అంటే అదే సార్, అంటే యాజ్ సూన్ యాజ్ పాసిబుల్, బట్ ఇది కంపల్సరీ 1 hour లో ఇమ్మీడియట్లీ ఇవ్వమని ఇచ్చారు సార్.
1 hour దాకా వెయిట్ చేయని అవసరం లేదని చెప్పాడు అన్న. ఇప్పుడు
లాస్ట్ ఒకసారి చదువు, లాస్ట్ టైం రికమెండేషన్ కొంచెం 19 లో 20 లో ఒక మోడిఫికేషన్ వచ్చింది, చిన్న రికమెండేషన్, నాట్ 3 hours 1 hour అని.
అవును సార్, అవును. ఇది we recommend that administration of intravenous antimicrobials should be initiated as soon as possible after recognition and within 1 as soon as possible, but ఇది కంపల్సరీ ఇమ్మీడియట్ గా ఇవ్వమని ఇచ్చారు సార్ కొత్తగా. దాంట్లో as soon as possible ఇచ్చారు, దీనిలో కంపల్సరీ ఇమ్మీడియట్లీ అని ఇచ్చారు.
గ్రేడ్ ఆఫ్ రికమెండేషన్ ఏంది
సార్? అది ఎవిడెన్స్ లేదు సార్, అంటే నేను ఇప్పుడు
రికమెండేషన్ లో క్వాలిటీ ఆఫ్ ఎవిడెన్స్
ఫర్ సెప్టిక్ షాక్, ఫర్ సెప్సిస్ వితౌట్ షాక్ స్ట్రాంగ్ రికమెండేషన్, వెరీ లో క్వాలిటీ ఆఫ్ ఎవిడెన్స్.
ఓకే, క్యారీ.
So we recommend that administration of intravenous antimicrobial should be initiated as soon as possible after recognition and within 1 hour for both septic shock and sepsis without shock. So for adults with possible sepsis without shock, we suggest a time-limited course of rapid investigation, and if concern for infection persists, the administration of antimicrobials within 3 hours from the time when sepsis was first recognized. For they advised in 2016, antimicrobials should be initiated as soon as possible for both septic shock and sepsis without shock. But they said in 2021, we can give possible sepsis without shock. Within 3 hours we can give, not immediately within 1 hour. The administration of antimicrobial should be given within 3 hours from the time when sepsis was first recognized. So regarding another recommendation, we recommend that administration of intravenous antimicrobial should be initiated as soon as possible after recognition and within 1 hour for both sepsis and in 2016. So for adults with a low likelihood of infection and without shock, we suggest differing antimicrobials while continuing to closely monitor the patient. So it is like 2016 only, whenever there is no possibility of very less likely of sepsis, then avoidance of antimicrobials is preferable. So, and another recommendation for antibiotics is we recommend empiric broad spectrum therapy with 1 or more antimicrobials for patients presenting with sepsis or septic shock to cover all pathogens. So So for adults with sepsis or septic shock at high risk of MRSA, we recommend using empiric antimicrobials with MRSA coverage or using antimicrobials without MRSA coverage. So whenever we are suspecting MRSA, so patient who was admitted within for at least for more than 48 hours in last 3 months, they are considered as a risk factor for MRSA, and patients who are in nursing homes, who are healthcare workers, who are in any even old age homes also considered as a presence in high risk group. So for those patients, we have to initiate MRSA coverage as soon as possible without using antimicrobial without MRSA coverage whenever patient is not in the risk factor. So, and another recommendation for antibiotics is we recommend empiric broad spectrum therapy with 1 or more antimicrobials for patients presenting with sepsis or septic shock to cover all pathogens. So even including to cover bacterial, fungal, and viral. Now they recommended same for MRSA. Whenever MRSA is there suspected, then we have to give antimicrobials against MRSA. If there is no risk factor, then no need to give against MRSA. Sir, inko do the 1 minute share. Yes, sir.
Next question.
Sir, ఇదే కంప్లీట్ అవ్వలేదు సార్, ఒక్క నిమిషం షేర్ చేస్తున్నాను. So for adults with sepsis or septic shock at high risk for fungal infection, we suggest using empiric antifungal therapy or no antifungal therapy. So patients who are at risk for, in 2016, they said that we recommend empiric broad spectrum therapy with 1 or more antimicrobials for patients presenting with sepsis or septic shock, including bacterial. Now they recommended patients who are high risk for fungal infection. They said to use antifungal therapy. They said to start antifungal therapy also concurrently with antimicrobials. So antibacterials. For us with sepsis or septic shock, whoever are low risk for fungal infection, they suggested against using antifungals. So hemodynamic management, and for adults with sepsis or septic shock, we suggest using balanced crystalloids instead of normal saline for resuscitation. Previously, they said either balanced crystalloid or saline we can use, but now they recommended to use balanced crystalloids instead of normal saline. They said strictly, they said in 2016, either balanced crystalloid or saline we can use, but now they recommended to use balanced crystalloids instead of normal saline for resuscitation. So, and for adults with sepsis or septic shock, we suggest against using gelatin for resuscitation. In 2016, they said that we suggest using crystalloids over gelatin. They just said we can use gelatin. They said they recommended crystalloids over gelatins in 2016. Now they said that they are against gelatin. They said strictly not to use gelatin in resuscitation of the patients, hemodynamic resuscitation. So there is insufficient evidence to make a recommendation on the use of, for adults with septic shock, we suggest starting vasopressors peripherally to restore mean arterial pressure rather than delaying initiation until a central venous access is secured. So previously there was no recommendation, but to use vasopressors to use in central line only. Now they strictly said we can initiate even in peripheral line to restore mean arterial line. No need to wait for central venous access. It was not recommended in 2016, and there is insufficient evidence to make a recommendation on the use of restrictive versus liberal fluid strategies in the first 24 hours of resuscitation in patients with sepsis or septic shock who still have signs of hypoperfusion and volume depletion after the initial resuscitation. So for adults with septic shock and ongoing requirement for vasopressor therapy, we suggest using IV corticosteroids. Previously, in 2016, they said that if the patient is not responsive, then we have to give fluid resuscitation, and then we have to wait and we have to start corticosteroids. But now in 2021, they said we have to use we have to start IV corticosteroids as soon as possible of recognition of septic shock, and ongoing, even for ongoing requirement of vasopressor, then we have to start IV corticosteroids. In 2016, they suggested we suggest against using intravenous hydrocodone to treat septic shock patients if adequate fluid resuscitation and vasopressor therapy are able to restore hemodynamic stability. If this is not achievable, we suggest IV hydrocortisone at a dose of 200 milligrams per day. So previously they said that we have to, after resuscitation, we have to start IV corticosteroids. But now it is recommended to start vasopressors, corticosteroids along with fluid resuscitation. So for adults with sepsis, we suggest using polymyxin B hemoperfusion. We make no recommendation against regarding the use of blood purification techniques. Previously, they didn't recommend anything for blood purification techniques, but they said now in new guidelines, they said against. So not to use polymyxin B hemoperfusion as an additional therapy. And another recommendation for adults with sepsis or septic shock, we suggest against using IV vitamin C. So because of high risk of renal failure, that is not to use that. So next question coming is
Raghu, clarify about polymyxin B. You told about polymyxin B something.
1 minute, sir. Sir, polymyxin B, not to use polymyxin B, sir. Previously, they recommended to use polymyxin B. No, they made no recommendation for blood purification techniques, but now they are against using polymyxin B for.
ఇది డ్రగ్ కాదన్నా, ఇది ఫిల్టర్స్ గురించి.
Filters. Yeah, you are telling about
hemoperfusion.
It is not the drug. It is other filters, cytosol gaani, polymyxin B gaani, filters గురించి they mention. Raghu, when you tell to an examiner, you should be very clear.
Okay.
Polymyxin B not to use అంటే అనుకుంటాడు, నువ్వు వాడట్లేదు అనుకుంటాడు.
Okay.
Right.
Raghu, another question to you.
Sir.
You said antimicrobials can be given within 3 hours of sepsis without shock.
Yes, sir.
Antimicrobials should be given immediately when patient in septic shock. How do you differentiate sepsis from septic shock within 3 hours or within 1 hour?
Sir, same, sir. We have to see blood lactates and we have to see for blood pressure, sir.
What is the criteria of septic shock to define septic?
More blood lactate should be more than 2 millimoles, and MAP should be less than 65, sir.
Okay, if both are there, but the patient BP is labile, that means the patient BP is a borderline. As per the sepsis guidelines, hypotension is less than how much?
MAP less than 65, and if it is less than 30 millimeters of mercury,
is it MAP or systolic blood pressure?
Systolic blood pressure less than 90 and MAP less than 65. So both can be considered.
Less than 90 or less than 100?
Less than 90, sir.
What, Jekina? Is it correct?
Yes, sir. Less than 90 systolic blood pressure.
But as per that SOFA score is there, no, that is less than 100. They have mentioned less than 100.
That is
Not
an
something.
organ scoring system, kada?
Yeah, na?
That is an organ scoring system. So here definition is less than 90, or even or map less than 65, or అది రెగ్యులర్ బ్లడ్ ప్రెషర్ కంటే 20-30% ఏదో ఉంది, అది నాకు కరెక్ట్ గుర్తులేదు.
30%, 30 millimeters of mercury of
బట్ అది డిఫికల్ట్. సో దీస్ టూ we can
because with the why I'm asking, majority of the patients coming to casualty with blood pressure of 100/60 or 100/50, as per your guidelines, it may not meet the septic shock criteria, but within a few minutes or within half an hour, patient may go into hypotension. So
see what happens is usually this patient comes with around, as you mentioned, 100/50 or something. So MAP will be around 65 to 70. But if you take immediately ABG, lactate may or may not increase. But this depending on the symptoms, anyway you have to start on an antibiotic. And this usually what happens is sometimes we see from emergency they give fluid bolus, then blood pressure will increase, again they will give fluid bolus, again it will increase. They even don't start vasopressors also, and by the time the patient comes to medical ICU, the patient will be BP will be low, because the prediction is very important. And there is a capillary leak. Whatever the amount of fluid you are giving, it is going to have a capillary leak. So depending on the clinical this one criteria, or a lactate or SBP less than 90, or suppose if it is 100 means it will not stay in the same range. No? Next after 5 minutes, if you say take the blood pressure will be dropping around 95 systolic. At that time immediately you can start. See, blood pressure drop can be because of various reasons also. It can be cardiogenic shock, but until you get a clear clarity, better to, there is no harm in starting antibiotic.
Sir, second point just I wanted to add is 100 BP what we are speaking about, or 90 BP what we are speaking about, might be low for a hypertensive patient who is used to a pressure of 140 or 130, whose baseline pressure is 130, 140, 150. Obviously, we should consider 90 or 100 as a hypotension. So,
yes, yes, 30 millimeters of mercury of baseline also should be considered as a shock.
So it should be the clinical.
That actually it is very difficult to identify. Why? Because see, as per the hypertension, these guidelines, AHA, everybody's blood pressure has to be normal, irrespective of their blood pressure. Yeah, hypertension cannot be 150 or 160.
So sir, we have the JNC guidelines which says that we target up to 130 or 140, not less than that. 120 ani manaki ive levu. So what we target is 130. But a patient who is hypertensive, who has not taken the medication in the morning or because of something, and his BP is 100, obviously we'll consider it as a hypotension.
Yes, agree. Adi hypotension anaju. Kani idi gray area ante మనం నువ్వు తీసుకున్నావా లేదా ఇది అని కంటే కూడా 100, as you mentioned, we can take a liberally as a 100 కూడా యాంటీబయాటిక్ స్టార్ట్ చేయడంలో. దట్ clinical scenario ఉంటుంది కదా.
Yes, it is the trend and the clinical scenario which guides.
ఏ పేషెంట్ చెప్తాడు ఫీవర్ ఉందమ్మా, నాకు ఆయాసం వస్తుంది, then your blood pressure will be systolic 100, then you can start an antibiotic. So what if it is sepsis only? What they are saying, if sepsis, should we start or should we not start? Recommendation
in sepsis we can wait up to 3 hours, we can evaluate, but septic shock immediately we have to start antibiotic.
Yeah, definitely. Okay.
What is the value of lactate in sepsis or septic shock?
More than 2, sir. 2 millimoles.
So what is the, what is the value of lactate in the sense? What is the which is more which has more mortality? Which value has more mortality?
More than 4, sir. More than 4, and lactate clearance less than 10%.
So the mortality percentage.
What duration?
Sir, mortality
mortality. What is the mortality when lactate is more
కాన్ఫరెన్స్
than
రూమ్
more
ఉంది
than
కదా
4?
ఓకే బాయ్
Sir, question వినపడలేదు sir.
What is the mortality? What is the percentage of mortality when your
Okay.
lactate is more than 4? And what is the percentage when your mortality is more than 2?
Sir, more than 4 it is around 40%, sir. More than 2 it is around 10%, sir.
Rendu tappe. Mortality more than 4 is around 28 to 30%. And more than 2 or 2.5, what we take, it's more than 22 to 25%. And what is the lactate clearance that you have to achieve?
In 6 hours, we have to, it should be decreased more than 10% of previous value.
No, 20%.
Okay, sir.
No, what is the, as you said rightly, as you said, value of the lactate is important, value of the, what you asked me?
Lactate clearance is important.
Lactate clearance important, more important, లేకపోతే drug product more important అడుగుతున్నా?
నేను అడిగిన just value of
Lactate important, clearance important.
in management of sepsis. What is the value or what is the role of lactate in management of sepsis? That's my question.
So as you said, you have to every 6 hours, yeah?
Maybe we have to repeat after 6 hours to see in which trend we are going off.
Thank you.
So my next topic of discussion is quality indicators of
any queries from anyone on sepsis, these guidelines? Sadiq sir, you can add, no? Sadiq sir unnar kada?
Sir, on bye sir discussion anta no, carry on please.
Okay sir.
Next topic.
Yeah, please carry on.
Next topic is quality indicators. These are more less studied by many people in ICUs. But
అసలు క్వశ్చన్ ఏంటి చదువు రఘు, క్వశ్చన్ ఏంటి?
Quality indicators of ICU, sir. I think
లేదు, క్వశ్చన్ చదువు మొత్తం.
అదే సార్, quality indicators and their positives and negatives.
Positives and negatives అని ఏమి ఇవ్వలేదా నేను?
Quality indicators of ICU and its limitations.
Its limitations.
ఎంత క్వశ్చన్ నెంబర్ ఎంత?
7 sir, 7.
సార్ నేను డ్రైవింగ్ చేస్తున్నాను. మోహన్ సార్ ఏంటి సార్ అది?
What are the quality indicators in ICU and what are their limitations?
Okay. Yes, please go on.
So quality indicators, what we see, it is this is a document.
You know, see, quickly explain about the quality indicator, its use and its limitation. Quickly.
Okay sir.
15 minutes ఉంది కదా.
So first thing is standard mortality rate. Standard mortality rate is a risk-adjusted mortality rate. Mortality rates are not often indicators of performance. I will tell rationality. Risk of death varies with severity of the disease, state, age, and comorbid condition. So crude mortality, therefore, is not a sensitive indicator. So on the basis of influencing factors, standard mortality rate obviates limitations of crude mortality as data from a large pool of patients with similar diagnosis and risk factors are analyzed to get expected mortality for that group of patients. So we have to compare standardized mortality for each observed. So how to calculate is observed rate divided by risk adjusted expected rate and multiplied by 100. So observed rate is actual death in ICU by institution. So this is a problem with standard mortality rate is observed rate we can get, but actual death we can know in ICU, but patients with the DNR status or any other comorbids, or it will be difficult to interpret in this standardized mortality mortality rate. That is the limitation of this. So how to interpretation is equal to 100. If SMR is standard mortality rate is equal to 100, then hospital's mortality rate and the expected average rate are the same. If it is more than 100, ICU mortality will be more. If less than 100, hospital mortality rate is lower than expected average mortality rate. So our treatment protocols are going good. That is the standard. Compared to other data, we have to compare standard mortality rate. If any disease is underdiagnosed, then the standard mortality rate of that particular disease will be decreased. It is very difficult to interpret that.
So, I'll give an example.
Sure.
మన మెడికల్ ఐసీయూలో మోర్టాలిటీ రేట్ ఈజ్ అప్రాక్సిమేట్లీ అరౌండ్ 10 to 15 ఎంత ఉంటుంది నిత్యానంద్ చెప్పగలుగుతాడు బికాస్ ఈస్ క్యాల్కులేటింగ్. సో అరౌండ్ 15 ఉంది అనుకో సపోజ్ మెడికల్ ఐసీయూలో. సర్జికల్ ఐసీయూలో హార్డ్లీ ఎప్పుడో ఒకసారి పోతారు పేషెంట్. ఒక 5 ఉంది అనుకో.
ఓకే సార్.
సో హౌ విల్ యూ కంపేర్ మోర్టాలిటీ రేట్ బిట్వీన్ ద సర్జికల్ ఐసీయూ?
అదే సార్, సేమ్ ఐసీయూ సెటప్ లో బయట కూడా వేరే దగ్గర గైడ్ లైన్స్ ప్రకారం ఇంటర్నేషనల్ గైడ్ లైన్స్ లో ఎంత మోర్టాలిటీ ఉంటుంది ఐసీయూలో అట్లా కంపేర్ చేస్తూ.
సో ద అడ్మినిస్ట్రేటర్ సేస్ దట్ my surgical ICU is better than medical ICU, so you guys, we don't want your services. So you will compare with the care or other ICUs in other hospital, or how do you assess in hospital? లేకపోతే శ్రీ హోలిస్టిక్ తో కంపేర్ చేస్తావా? దేంతో కంపేర్ చేస్తావు మెడికల్ ఐసీయూ?
సార్ అది అంటే హాస్పిటల్ డెత్ మొత్తం డెత్ తోటి సార్.
హాస్పిటల్ డెత్ మొత్తం అంటే ఇక అసలు వాటిలో చచ్చేపోరు, అసలు వాట్స్ ఆర్ డూయింగ్ బెటర్ కదా
సార్. ఇది యాక్చువల్లీ దీని ప్రకారం అయితే మనము వేరే ఒక స్టాండర్డైజ్ మోర్టాలిటీ రేట్ తీసుకుని దాంతో కంపేర్ చేయాలని.
ఎట్లా తీసుకుంటావు స్టాండర్డైజ్ మోర్టాలిటీ రేట్?
Yeah, is clearly given what is the predicted mortality as per the standard models. Predicted models is you have mentioned no already.
Yes sir.
See there, mortality rate can be obtained from the predictive models such as Apache, SAPS, and SOFA.
Adi, so you should calculate that things. Ivanni, that's the reason why my question is very straight. Limitations and పెట్టాము అందుకనే. So you have to calculate as per the Apache or SOFA score, and then you have to tell that, see that their mortalities you have to calculate, and then what is your mortality you have to tell it. Okay?
Okay.
Any addition, sir?
Are you calculating really the SOFA score, Apache, or SAP score in your ICU for all the patients?
No sir, no.
Calculated, but actually once one administrator or administrator asked us, so I want to see your quality of ICU. So we calculated for around 6 months to 7 months Apache 2 scoring system. And we have shown we are much better than this Apache 2. Obviously, that is to show to them, because this Apache 2 is the oldest model, and where at that time the standard of critical care is not very high. So that's the reason why we will be definitely above the Apache score, better than Apache score.
Sir.
Systems.
Hello. Hello.
Sir. Yeah. Please.
NABH standard 5 ఇప్పుడు present running దాంట్లో they clearly wanted this quality indicator should be attributable to the particularly this mortalities and morbidities attributable to Apache existing 3 score.
Okay.
As per the quality standards presentation untadi kada, దాంట్లో they clearly mentioned we have to maintain that Apache scoring and attributable mortality to that, and ultimately those are the things which guide our hospital indicators.
Apache 3?
No, Apache hospital indicators వేరు, AC indicators వేరుగా సతీష్.
అవును సార్, ఇప్పుడు we are talking about ICU. ఇప్పుడు మొత్తం ఇండికేటర్స్ హాస్పిటల్ ఇండికేటర్స్ లో ICU కూడా పార్టే కదా. ICU ఇండికేటర్స్ లో మార్టాలిటీ గురించి they clearly mention that we have to consider the Apache scoring or any scoring system against our mortality. That we need to mention that.
Yes, sir. We are implementing actually. If 15th, we are starting that one because we just had discussion with the that they're implementing it.
Sure.
Yes, sir.
Sinu, Jekina, or Monangaho, David, whoever it is, Satish. Apache 1, Apache 2, Apache 3. What are the differences and what are the limitations?
Apache 3 లో మనం ఒకసారి స్కోరింగ్ సిస్టమ్స్ అన్ని
Sir.
డిస్కస్
We will talk on scoring system in a other topic because it is difficult to discuss. It's a new topic, no? They may not remember these differences.
గుర్తుండవు కూడా. అవును, గుర్తుండవు ఇప్పుడు.
Guttundava. Yes, sir?
Yes, sir.
Right. You carry on, Raghu.
Yes, sir. So next coming, first we discuss mortality parameter. Now we are going to discuss about morbidity parameters. Morbidity parameters, procedure related pneumothorax is considered as a one of the indicator, quality care of indicator. So number, how to calculate is number of pneumothorax by number of cases multiplied by 1000. So it should be less than 0.83. Nowadays we are using ultrasound. That's why iatrogenic pneumothorax chances are very less. Sir, దీని లిమిటేషన్ తెలియదు సార్ యాక్చువల్లీ నాకు.
న్యూమోథోరాక్స్ కి ఇంకా దానికి లిమిటేషన్స్ ఏముండవు న్యూమోథోరాక్స్ కి.
Okay, incidence of acute renal failure in non-coronary ICU. This is also one of the quality indicator. So how to calculate is number developed severe renal failure by number managed in ICU. The pitfall, basically problem with this acute renal failure incidence calculation is if patient has background any CKD or CKD is there, then it is very difficult to interpret. That is the pitfall of the limitation of this acute renal failure in non-coronary ICU. So if patient has any decreased baseline, if never investigated, if baseline serum creatinine is higher side or at borderline, then it is very difficult to interpret this thing. And we have to, and we use serum creatinine base, but we have to use GFR thing also to know the renal failure status. So decubitus ulcer is also one of the morbid.
ఇంకా ఇష్యూస్ ఏంటంటే see when you are limitations means each ICU or each group of patients when we are comparing, there will be a little higher risk in sepsis patients AKI and also surgical ICU to compare చేస్తే కొంచెం higher risk of patients with AKI. And also coronary ICU also there will be a little higher risk of AKI as the patients undergo contrast ఇస్తారు కాబట్టి contrast properly. So these are the things. So
next another morbidity indicator is decubitus ulcer. This is the one of the important thing in ICUs. Why? Because of chronic because of bedridden status, non-ambulating, they are high risk for decubitus ulcer. That's why decubitus also one of the care indicator. How our nursing care will be seen with this decubitus ulcer. So this is number of pressure ulcers by number of cases multiplied by 1000. This is in our hospital. We are following second hourly position change. We have a chart we have a document paper to document change position of the patient every second hourly, and we have pasted many posters how to maintain position at what time, what position should be maintained. We displayed in our whole ICU and in the hospital also to decrease the pressure ulcer. Problem with pressure ulcer is even with device related ulcers also can be seen, like NIV or any chronic in cases of CKD. If patient is on dialysis, it's very difficult to change the position, and this is the problem with decubitus ulcer. If patient requiring more RRT, if we cannot shift the patient, That is the problem. That's why incidence can be more in those patients. That is the problem with decubitus ulcer.
So we have done an comment on ulcers, decubitus ulcers. Actually, initially last 1.5 year back, we have a lot of major ulcers developed in the hospital. So even though we are putting the charts, it is not decreasing. So we started auditing it. So when we started auditing, the patient is in one position, on the chart it is documentation is other position. It was almost hardly 30% it is coinciding with the documentation and the patient actual position. So we started quick audits, and then we presented to them, to the concerned in charges. Then automatically the compliance has increased, and the decrease in the decubitus ulcers we have seen. Please go ahead.
So next, another operational or process parameter is length of stay. Length of stay is one of the indicator, and how our ICU is taking care, how patient outcome is there. But problem how it is calculated is total occupied bed days divided by number of patients in a given time frame, like weekly, monthly, or yearly. This we have to calculate. But problem with the length of stay is, if any hospital has high mortality rate, then the length of stay will be spuriously decreased. So that is the problem with length of stay.
Length of stay can
Sir?
mortality ki length of stay difference in link enduku?
అంటే మోర్టాలిటీ ఎక్కువ ఉన్నప్పుడు లెంత్ ఆఫ్ స్టే అనేది తగ్గుతుంది కదా సార్. అట్లా స్పూరియస్ గా మనం తక్కువ స్టే ఉంటున్నారు అన్న ఒక రాంగ్ ఇంటర్ప్రిటేషన్ వస్తుంది.
డెత్ అంటే ఎర్లీ డెత్స్
సార్,
నాట్ లేట్ డెత్స్, ఎర్లీ డెత్స్. ఒకటి
ఎర్లీ డెత్స్. ఎస్.
ఇంకా what will be the length of stay in SICU and what will be the length of stay in MICU?
So SICU length of stay will be very less, sir. Post-operatively, if patient become conscious oriented, then they will shift 4 to 6 hours, sir. But in our ICU, after treating if we consider patient is able to sustain without any supports, then we shift to...
because those are less sick patients kada, elective patients. Mana is sick patients. It needs time for improvement. So length of stay, because we have a lot of comorbidities.
Yes. And compliance to protocol, selected compliance to protocol, we have to observe number of time followed by number of time.
Suppose
sir,
length of stay పెరుగుతుంది అనుకో ఈ ICU లో. You know what is the length of stay in our ICU?
Sir, గుర్తులేదు సార్, చూసినా కానీ గుర్తులేదు.
So that's the reason why quality indicators are projected. నిత్యానంద్ చేస్తున్నాడు. Suppose if our length of stay is approximately 4 to 5 days. Suppose if it is increasing, then we can why it is increasing, then we need to evaluate.
Okay. Next, compliance to protocol, number of time followed by, when we form some protocols, we have to observe when the number of time followed by number of time expected to follow multiplied by 100. This is a problem, limitation of this compliance protocol. There should be strict monitoring system. Then we have to see compliance of each and every staff, our patient. It is very difficult to be there at that place every time. That's why we have a linked nurse system in our hospital. They will observe the compliance to protocol and they will report to the in-charge sister of infection control. We have a linked nurse system for this assessment of compliance to protocol system.
So infection, inkemunna compliances? What compliances?
Sir, resource utilization, patient care, iatrogenic complications, ivanni compliances.
ఏమేమి చెక్ చేస్తారు? How do we check it?
సార్, మన దాంట్లో అయితే అది వేరే అబ్జర్వ్ చేస్తాం. అండ్ ఈవెన్ ఇన్ఫెక్ట్ ఈ మన మార్బిడిటీ పారామీటర్ డెక్యుబిటస్ అల్సర్స్ లేకపోతే కాటీలు, క్లాప్సిల్లు అవి పెరగడం కూడా వన్ ఆఫ్ ద ఇండికేటర్, కాంప్లియన్స్ ఫాలో అవ్వనట్టు సార్.
కంప్లైంట్స్ ఫాలో అయినా కానీ
What are the criteria of surveillance of your complaints? You have to give the rate of complaint, not this much percentage of following your guidelines.
మీకు కాటీకి ఏముంది, ఇండికేటర్స్ ఏమున్నాయి, ఏమైనా
Who will
ఇండికేటర్ కాకుండా నీకేమైనా వాడతారా?
బండిల్ ఉంటుంది సార్, క్యాథెటర్
బండిల్ చెక్ లిస్ట్ మరి ఆడిట్ చేస్తే తెలుస్తుంది కంప్లైంట్స్ ఏందనేది.
That's what you have to tell what criteria you will follow for checking the complaints.
So you will have admission, discharge criteria from ICU, అవన్నీ ఉంటాయి కదా కంప్లైంట్స్.
అవును సార్.
And hand wash complaints, this thing.
Yes sir.
How will you check hand wash complaints?
సార్ అదే సార్
following.
సార్ మా దగ్గర అయితే లింక్నర్ సిస్టమ్ ఉంటుంది సార్, వాళ్ళు అబ్జర్వ్ చేస్తారు ఎంతమంది చేస్తున్నారు హ్యాండ్ వాష్. ఈవెన్ టచ్ ఇన్ఫెక్షన్ కంట్రోల్ సిస్టర్స్ ఉన్నారు, అండ్ ఎవ్రీ వార్డ్ హ్యాస్ సమ్ వన్ లింకర్స్. దే విల్ అబ్జర్వ్ complaints and they will report to concerned sisters.
What criteria they will follow to say the percentage of complaints?
Sir, అదే సార్ నెంబర్ ఆఫ్ టైమ్ ఫాలోడ్ అండ్ నెంబర్ ఆఫ్ టైమ్స్, అంటే ఎన్నిసార్లు చేస్తే అన్నిసార్లు కడుపు హ్యాండ్ వాష్.
They check into all the movements and all the
always they will stay with the sister.
నో సార్, అందుకే సార్ నెంబర్ ఆఫ్ టైమ్ ఎక్స్పెక్టెడ్ టు ఫాలో ఉంటుంది సార్. కంపల్సరీ అన్ని సార్లు ఫాలో అవ్వలేరు.
అదే they will expect and write, or they will see certain criteria to see the percentage.
They will see sir.
How they will see? No, directly they will come and see.
Yes sir. And
అదే సార్ ICU.
No sir, అందుకే సార్ ఎవ్రీ వార్డ్ హ్యాస్ వన్ లింక్ నర్స్. వాళ్ళు ప్రతి ICU లో ప్రతి యూనిట్ లో దే హ్యావ్ ఏ లింక్ నర్స్. అంటే ఆ నర్స్ అబ్జర్వ్ చేసి వాళ్ళ సిస్టర్ కి రిపోర్ట్ చేస్తారు సార్. అది సిస్టమ్.
These link nurses are not known to anyone. So these link nurses are not known to anyone, and they directly report to the infection control nurses. And these link nurses can come from wards to ICUs also. So they, whenever they are there, just they will be there for 15-20 minutes chatting with someone and like that, and then they observe and then they chart it.
And they can see the CC cameras for some time and watch the CC camera how much times they are doing washing.
CC cameras,
yeah, their linkers should not be known to the sisters that she is observing.
Yes.
Criteria is there. NABH will ask. Okay, carry on.
So next, ICU readmission rate. ICU readmission rate is considered a patient transfer within 24 hours of transfer during a single hospital stay. This is an indicator of post ICU care. Limitation of this thing is a zero readmission rate reflects more defensive approach by ICU team, which increases the length of stay in the hospital and increases risk for nosocomial infection, iatrogenic complication, and non-availability for the deserving patients. It itself increases higher mortality for non-available because of non-availability. So this is the problem with the ICU readmission rate. Sir, ఇది ఏమన్నా యాడ్ చేస్తారా సార్? ఇంకా
length of stay na?
కాదు సార్, readmission rate.
Readmission ki actually you need to know whether the patient ki enduku readmission చేసేటప్పుడు you can see look into the quality of your both ICU and the ward. So early ga, if your criteria is not fitting and the patient gets out early from the ICU, this patient can get admitted, readmission to ICU. Okay, కొన్నిసార్లు మనకు అవుతుంటది కదా, పేషెంట్ డెలిరియస్ ఉంటాడు, షిఫ్ట్ చేయండి అంటారు, డబ్బులు లేవని మళ్ళీ వస్తాయి కదా బ్యాడ్ షేప్ లో.
Yes sir.
Or some borderline patients where ఈవెన్ ఆక్సిజన్ బయట అన్నిటి మీద కూడా పంపిస్తాం కొన్ని పేషెంట్స్ బాగానే ఉన్నా స్టేబుల్ ఉన్నా ఐసీయూ క్రైటీరియా ఫిట్ అయినా కానీ బట్ దీస్ పేషెంట్స్ కమ్ బ్యాక్ బికాస్ ద నర్సెస్ మనం చూసాం కదా డజంట్ నో హౌ టు పుట్ బైపాప్ హౌ టు పుట్ ఆల్ దిస్ థింగ్ సో పేషెంట్ కమ్ బ్యాక్ టు us. సార్ మోహన్ సార్ మీరు ఏమైనా యాడ్ చేయగలుగుతారా?
So next another indicator of care is error and patient safety care is patient fall rate. So patient and untoward event which results in the patient coming to rest unintentionally on the ground or on the lower surface. This is the number of falls by number of bed days multiplied by 1000. This is one of the indicator how we are delivering nursing care. Then coming to the medication error could be due to wrong prescription dosing or due to communication gap. So medication error rate is number of error by number of bed days multiplied by 1000. So medication error limitation of this thing is many under report dosing like IM, IV. This is also considered as a medication error. This is limitation of this is every time everyone won't report. So for this we have to very strict compliance system, and we have a in our hospital we have a signing. We have to sign whenever we give medication to the patient. So that's how we decrease the medication error in our setup. So in ICU drug chart they have to sign whenever they give drugs. They have to sign. That's how we are decreasing medication error.
How do you know that after signing she is given or not?
సార్ అది సిస్టర్ మళ్ళీ వాళ్ళ ఇన్ఛార్జ్ సిస్టర్ క్రాస్ చెక్ చేశారు సార్.
అవును, సైన్డ్. నువ్వు చెక్ చేసావు, నేను చెక్ చేసాను, ఇన్ఛార్జ్ సిస్టర్ చెక్ చేసింది. ఇట్ ఈస్ సైన్డ్. You are thinking that drug is given to the patient, but how do you know confirm that drug is really given or not? There are so many incidents. They are just taking out the.
Sir, vials కూడా చెక్ చేస్తాం సార్.
పడేస్తారు కదా, అక్కడ ఎందుకు పెడతారు? అక్కడ పడేస్తారు కదా.
ఒకవేళ పెట్టినా సరే కన్ఫర్మ్ చేయలేము సార్, అది ట్రూ. ఒకవేళ పెట్టినా సరే ఈవెన్ ఇఫ్ ఇన్స్ట్రక్ట్
సిస్టమ్ టు కన్ఫర్మ్ ఇట్ రఘు.
సార్
ఏమన్నా సిస్టమ్ ఉందా
సార్? మనం అంటే సిస్టమ్ అంటే ఇండియన్ పెట్టినా లేదా చూస్తారు, దాని తర్వాత ఇది ఇచ్చినా లేదా క్రాస్ చెక్ చేస్తారు సార్. క్రాస్ కౌంటర్ సైన్ ఉంటుంది సార్.
సైన్ కాదబ్బా, నువ్వు సైన్లు ఎన్నైనా చేయొచ్చు. నేను ఒక రోజు వచ్చేసి మొత్తం ఉన్నాయని చేయలేమా? నేను
చేస్తున్నా కదా.
ఏముంది, నర్స్ వచ్చేసి ఏమి ఇవ్వకుండా పోయేటప్పుడు మొత్తం సైన్లు చేయకపోతుంది.
కౌంటర్ సైన్ సార్, కౌంటర్ సైన్.
కౌంటర్ సైన్ ఇంకోళ్ళు కూడా దోస్తులు చాయ్ తాగిస్తే వాళ్ళు కూడా చేస్తారు.
దాన్ని ఎలాగా కన్ఫర్మ్ చేస్తావు?
ట్రీట్మెంట్ అవుట్కమ్ సార్, పేషెంట్ అవుట్కమ్.
Is not the issue, depends on this.
క్లినికల్ ఫార్మకాలజిస్ట్ వాడు వచ్చి ఆడిట్ చేస్తుంటాడు, చూసావు ఎప్పుడన్నా?
చూసా సార్.
వాడు ఏం చేస్తుంటాడు, ఎన్ని మీరు ఇండెంట్ పెట్టారు, ఎన్ని ఇచ్చారు, ఎన్ని ర్యాక్ లో ఉన్నాయి, ఎన్నింటికి బిల్ అయినాయి, ఇవన్నీ చెక్ చేస్తుంటాడు కదా వాడు.
అవును సార్, అవును సార్.
మరి అదే కదా.
That's the clinical pharmacist. And the another thing is the drug should not be discarded. That empty vial should be kept at the bedside.
ఉండదా అన్న ఇది?
ఉంది.
అన్నిటికి ఎంటీ వైల్స్ పెట్టరు మరి మన దగ్గర.
If you have doubt, you can follow that.
Important drugs ఏమైనా డౌట్ఫుల్ కాస్ట్లీ డ్రగ్స్ కి మనం పెట్టొచ్చు.
అదే కాస్ట్లీ డ్రగ్స్ పెట్టొచ్చు. కాస్ట్లీ డ్రగ్స్.
Yeah, costly drugs only. High
and especially when they are giving to some insurance కానీ BHL కానీ ఇట్లాంటి కంపెనీస్ కి కొన్ని పెట్టాల్సి వస్తుంది.
Insurance people are asking to show that. Yes, they will come and check also. Clinical
sir.
Yeah.
Next coming is needle stick injury rate. So this is calculated as the incidence per 10,000 VNA punches. So limitation of this thing is patient every time reporting will be very less, under-reported. This is the main limitation of this. Many people won't repeat because of some fears or something. So very less reported. This is the main limitation of this thing. So reintubation rate, reintubation within 48 hours of extubation is a one of the important indicator in ICU. So if accidental extubation and subsequent reintubation can lead to prolonged stay, longer ventilation, and higher nosocomial pneumonia and mortality. This reintubation rate will indicate our compliance of the extubation criteria. Then we have to check our extubation criteria. We have to reassess, reform our extubation criteria if reintubation rate is more than 12%. So next coming the infection control quality indicator.
Raghu, if it is less than 5%, what is your inference?
Sir, our extubation criteria is good or not, sir?
It is as correct as
ఎక్కడ నుంచి వచ్చింది 12%? Where is this number 12% has come from?
Sir, ఆ స్టడీ ఉంది సార్ అది.
సరే ఓకే, వాడు ఏ పేషెంట్స్ ని ఇంక్లూడ్ చేశాడు?
సార్ అది స్టడీ చూడలేదు సార్.
మరి చూడాలి కదా, ఏ పేషెంట్స్ ఇంక్లూడ్ చేశాడు, ఎంత క్రైటీరియా ఉంది, వాళ్ళది ఏంటి, వాళ్ళ ఎక్స్ట్యూబేషన్ క్రైటీరియా. సరే ఇప్పుడు నువ్వు సపోజ్ ఎస్ఐసి ఉంది, ఎస్ఐసిలో రీఇంట్యూబేషన్ ఎక్కువ ఉంటుందా, మన దగ్గర ఎక్కువ ఉంటుందా?
ఎస్ఐసిలో ఎక్కువ ఉంటుంది సార్.
ఎందుకు?
ఎస్ఐసిలో ఎందుకు ఉంటుంది ఎక్కువ?
మెడికల్ ఐసీలో ఉంటది కదా, ఎస్ఐసిలో ఉంటావేంటి రఘు?
సార్
ఎస్ఐసి వాళ్ళు అంటే అక్కడ తోలిస్తారు జనాలు. అంటే మెడికల్ ఐసీలో ఉంటాయి కదా, సిక్ పేషెంట్స్ ఉంటాయి, ఎక్స్ట్యూబేషన్ రీఇంట్యూబేషన్ ఎక్కువ అవుతుంటాయి కదా. ఎస్ఐసిలో ఏమున్నాయి, వాళ్ళు ఎలెక్టివ్ కేసెస్ కదా.
అవును సార్.
See, every percentage, that is, if you say is less than very nice percentages, less than 5, less than 4, or less than 6, these percentage doesn't directly indicate that you are strictly following the extubation guidelines. That need not be necessary. Okay. So when you are not, when your deaths are very high, that also gives a false impression. Second, when you're not doing a proper or very delayed extubation, okay, then also you will get a very falsely low, and you are not extubating at a proper time. Your length of stay might increase, and your reintubation rate has come down. Okay, so you have to have some percent of extubation rate to say that you are extubating your patient on time.
Okay.
ఒకటి రఘు, శ్రీనివాస్, ఇది మనకు 10% లేదు కదా అని చెప్పేసి అన్నిటికీ ఎక్స్ట్యూబేట్ చేయకండి. థింగ్ ఈజ్ వీ నీడ్ టు
but very less rate, sir, very less rate అంటే
what happens is sometimes యూజువల్లీ మన దగ్గరికి ఏమవుతుందంటే పేషెంట్స్ వచ్చేసరికి 3-4 days బయట ఉండి అండ్ అది కొంచెం కంపై వస్తాయి. యూజువల్లీ వీఆర్ ఆల్ వర్కింగ్ ఇన్ కార్పొరేట్స్ కదా, సో అవి 7 days 8 days కాగానే వీ గో ఫర్ ఎ ట్రెక్యాస్టమీ ఆర్ sometimes we may extubate or we may not extubate. So idantha, these are all little complicated things. Yes, you, as you mentioned that, I say that if we don't have any reintubation rate, that means we are not extubating early when the criteria fits. But ultimately the criteria has to be fit to extubate patients. That is more important.
Yes, అంటే నేనంటుంది falsely low, అంటే less than 5%, less than 4% is falsely low for a medical ICU. That's what I wanted to interpret.
Yes. So already 9:59. Should we stop at
sir? Sir,
చెప్పండి డేవిడ్ సార్.
అయిపోయిందా
సార్? ఇంకొక
చెప్పండి మరి.
అదే సార్, నెక్స్ట్ ఇన్ఫెక్షన్ క్వాలిటీ ఇండికేటర్ సార్, వ్యాప్ వెంటిలేటర్ అసోసియేటెడ్ pneumonia. So it is considered as the number of patients with VAP by number of mechanical ventilated days multiplied by 1000. We have to calculate. So VAP bundle, for in our hospital we have a VAP bundle we have a checklist. Every hourly they have to mention based on the heart rate, BP, and this SpO2, PEEP. They have to, and PF ratios. We have a checklist. They have to mention on that WAP bundle to recognition of early VAE or IVAC cases. And bloodstream infection due to central line, bloodstream infection rates is equal to number of central line related BSI per 1,000 central line days. So problem with this is it is very we have to get cultures of catheter that is very less done. For that culture we have to remove the central line. That is not possible every time. That is the main drawback of CLABSI. This thing, bloodstream infection due to central line. So for this prevention, we have a checklist bundle. Insertion bundle is there. We have to fill the checklist and we have to sign before doing any procedure to know the compliance of our protocols. And urinary catheter related infection, for this also UTI also number of UTI by number of catheter days multiplied with 1,000. For this also we have to mention a checklist to know the compliance and to prevent the urinary catheter related infection. Next coming Morton summarize. Sir, ఒక టేబుల్ ఉంది అది చూపిస్తా సమ్మరైజ్ క్వాలిటీ ఇండికేటర్స్ ఏంటి అని. సార్ దొరకట్లేదు.
Any questions from anyone?
Main
టైం
doubt
అయిపోయింది కదా.
అయిపోయింది.
final this thing Anna. All the quality indicators in our presentation, our regular monthly meet or this presentations, our people will give our WAP is 0, our bloodstream infection is 0.
Sir, away falsely low rates and comment చేసేది.
That's
It's
what.
a very negative thing.
Falsely low means that means either you are wrong reporting or you are not following.
We are not observing. Probably we are not observing.
Yeah, whatever it is. So whenever you have falsely low or 0, that means you are doesn't mean that you are doing very well, very good.
Yes, that's a first false indication.
Yes. So you must be very careful and look at your complaints, all these things, and correct reporting and properly following the checklist is very important.
Just I wanted to add one point again regarding this reintubation. But the values what we are considering is of like 2004, 5, 6 times, and after 4, 5 ఆ time లో ఉన్న values నే మనం ఇప్పుడు దాకా కన్సిడర్ చేస్తున్నాము, and we should reconsider after maybe recent studies lo we should reconsider it, and after evaluation of this HFNO and NIV post extubation, so the reintubation rates have been decreased, so maybe our percentage might change.
The last 2-3 points. Manpower, like per person training per year and appraisal of targets, staff satisfaction and turnover rate, these are also considered ICU indicators. Same, and resource utilization, like number of patient managed divided and number of bed occupancy and length of stay, or resource utilization and equipment also utilization in days or hours per month is also considered as a one of the quality indicators of ICU. Then we have to check these things also. And we have a feedback form in our hospital to know the customer satisfaction level. So whenever whoever patient discharges from the ICU, we have a form to fill, and they will give rating for every sisters, doctors, how they are behaving, and cost and everything. We have a form they have to fill before getting discharged from the ICU. So that's how we know the satisfaction level of the customers. Thank you.
Thank you, Raghu, for your all this presentation in a very short time without any notes. Yeah, thank you, Jekina, for making him to present immediately as soon as you asked.
Thank you, sir.
All the participants for your active participation. Thank you. Sorry for the delay.